Welcome to another EduMed video, and in this video we go through the mnemonic that's used to just check to make sure that all the different aspects of the patient's care are managed on intensive care ward rounds, and that is the so-called FLATCHUG mnemonic. Now, this mnemonic stands for F is feed, so always check that the patient is absorbing their feed, that they are on an appropriate amount of feed. If they're on TPN, so total parenteral nutrition, that there's been consideration made to think about changing them over to enteral feeding. L is for lines. Think about the lines that are in. Do they need the central line or the VASCAP that they've got in? Have they got the ability to move on to peripheral cannulas and peripheral medications? Do they even need the peripheral medication that they're having through their veins? Can they be changed over to oral medications? Any central line that has been kept in for more than 5 days, do consider changing it over. And similarly, any cannula that is being placed in peripherally, do think about changing it every 3 days. A stands for analgesia, so make sure that the patient isn't in pain. If they are, think about using opiate and non-opiate medications to try and manage their pain appropriately. This is really important in preventing patients from developing delirium. Aperients are really important. Ensure that patients don't get constipated. Generally, we try to aim for between 2 and 4 formed stool a day. If they've got a fecal management system in, then you want much looser stool so that the fecal management system doesn't get blocked. Always review the antibiotics that a patient is on. If they're not on antibiotics, consider if they have any infections. If they are on antibiotics, make sure it's the correct antibiotic, and so look at the microscopy, culture and sensitivities of any samples that have been sent. And if they are on antibiotics, also consider the duration. Try and stop antibiotics as soon as you can, because good antibiotic stewardship will prevent patients from developing multi-resistant organisms, either currently or in the future. Thrombo Prophylaxis must be considered in every patient. There should be a good documented reason why a patient doesn't get pharmacological thromboprophylaxis in the form of dolteparin or heparin or any of the other low molecular weight heparins. If they can't have pharmacological thromboprophylaxis, then do think about mechanical thromboprophylaxis in the form of TED stockings and Flowtron boots. Just a slight proviso with those patients: if they've got very poor circulations with peripheral vascular disease, do be careful with TED stockings, because they can reduce arterial flow into the legs or even venous outflow, and that can cause ischemia to the legs. Rare, but needs to be considered. Communication is really important, and this is really divided into 3 parts. One is communication with the nurse at the bedside, making sure that they're clear of the plan that's in place, and also communicating with them whether they have any concerns and addressing them appropriately. The second thing is to communicate with the base team for whom the patient came in under, making sure that they're updated of the progress and what is happening, and also asking them any questions about the ongoing treatment if their involvement is required. And the third thing is communication with both the family and the patient. Updating the patient is really important in giving them encouragement that they're improving, or explaining to them exactly what is wrong on a continuous repeated basis is vital to try and prevent delirium and to keep them apprised of what the situation is. With the family, it's really important to make sure that they understand what the condition is and how precarious patients on intensive care are. It's important not to give these family members false hope, and so re-emphasizing the fact that patients will ebb and flow between getting better and then having setbacks with things like intercurrent illnesses such as the ventilator-associated pneumonia. H stands for hydration. And make sure that you set a fluid balance for every patient, even if that fluid balance target ends up being own, and they can just take as much fluid as they want and they'll pee out. But for most patients, you want to be relatively strict and aim for, at the very minimum, between neutral and plus 500. And the reason for the plus 500 is that accounts for the insensible losses that patients lose through sweating, secretions, and stool. We must also make sure that all patients, if they can tolerate it, are head up. The reason for this is that it can prevent microaspiration around the endotracheal cuff and therefore decrease the risk of patients developing ventilator-associated pneumonias. Ulcer prophylaxis is really important, and so starting patients on a PPI, especially if they're not on an NG feed, and then reviewing that on a daily basis. Once patients are fully established on NG feeding and are absorbing, then it's worth considering stopping the PPI, and certainly we have seen evidence where the use of PPIs and the alkalinization of stomach acid can increase the risk of developing things such as ventilator-associated pneumonias and C. diff. Finally, glycemic control. Patients should certainly have sugar levels below 10, and considering the use of insulin is important in these patients. Also, making sure patients don't become hypoglycemic, especially in a hypercatabolic state that patients are often in when they first come to the intensive care, and also those patients for whom acute liver injury may cause acute hypoglycemia as well. So the FLATCHUG mnemonic should be used for every single patient, and before thinking about the plan for any patient, we should go through each of those points. If you don't know the answer to any of the points, then you must clarify it with either the base team or with a senior ITU consultant. There must be a plan for each section, and if there isn't, we could potentially be missing things and also providing inadequate care for our patients, which can prolong their intensive care stay.